Thank you. I'd like to thank the organisers and the IAS for the opportunity to present this work. Just have to... Okay, we're good. So I'm going to talk about... this is ridiculous. I feel like I'm going to fall over and I'm going to hunch. I'm going to talk about opioid substitution treatment and hepatitis C virus, some of the opportunities for prevention. I have no relationships with commercial interests and no conflicts of interest to declare. So people probably already know this, but hepatitis C virus infection is associated with a high global burden of disease. Approximately 115 million estimated to have been exposed, 3 to 4 million people newly infected globally each year, and about 350,000 people die annually. People who inject drugs are the key affected community. Of the estimated 16 million or so people who inject drugs globally, about 3 million are estimated to be living with HIV. However, few governments adequately recognise or address HCV in HIV and related public health programs. And this is to give you an example in Australia. This slide shows, I think in the red, HIV-related deaths, and in the blue, HCV liver-related deaths, and indicates that from about 1999, mortality from HCV liver-related deaths has consistently exceeded that from HIV. And this has also been the case in the US from 2006. Needle and syringe programs and opioid substitution treatment are the primary interventions to reduce both HIV and hepatitis C transmission among people who inject drugs. They're the first two elements of the WHO, UNODC and UNAIDS comprehensive package designed to respond to HIV among people who inject drugs. However, global coverage of these interventions remains extremely poor. So needle exchange, this is according to the UN reference group on HIV and injecting drug use from 2010, the latest estimates. Needle and syringe programs were present in 82 countries globally, or 54% of those where injecting drug use has been documented. However, 69 countries, or 46%, still do not have needle and syringe programs. And this slide shows that only 3 countries in the world, Norway, Australia, and the one I can't understand, Moldova, have what the UN group defines as high NSP coverage. And that's defined as distributing more than 200 syringes per injector per year. I think it's important to point out that that's such a conservative estimate of high coverage, not even 1 syringe per injector per day. But if we look at the global distribution, we only have 22 syringes distributed per injector per day. So think about that for a minute, how grossly inadequate that is. In relation to OST, 75, or about half of the 151 countries in which injecting drug use has been documented, have some kind of OST program. The other half, or 76 countries, have no OST. For example, in many of the countries in Latin America, people are injecting cocaine or stimulants, not opioids. So it doesn't mean that OST is indicated everywhere that injecting occurs. However, in many countries, most notably the Russian Federation, the lack of OST is significant. And while there are some limitations to these data, which I won't go into because a lot of programs don't actually count the number of people who are opioid users and opioid dependent who don't inject. These estimates suggest that globally only 8 out of every 100 people who inject drugs are in receipt of OST. So despite vigorous advocacy, global coverage remains grossly inadequate. Scale-up continues to be impeded by legal and regulatory barriers such as criminalisation, repressive policy environments which inhibit and deny access to these services. There's good evidence that NSP and OST in combination reduce injecting risk behaviours, and some evidence of impact on HIV incidence, but there's limited evidence of the impact on HCV incidence. And that's what I'm going to talk to you about today. I'm going to show you first some data from a recent prospective observational study of people who inject drugs in Australia, the HCV study, which we conducted as part of a program of hepatitis C vaccine preparedness research. Basically, we identified and followed 188 unexposed people who inject drugs over almost 6 years with very high retention and relatively low rates of incident hepatitis C infection. 7 per 100 person years overall, and only 1 case of incident HIV infection. And I'm proud to say that that 1 case of incident HIV infection is the only case that we've diagnosed my team has diagnosed in 25 years of doing observational research in Australia. So we created a composite variable because we were interested in particular the impact of OST on incident hepatitis C infection, which there was no evidence for. We used a parametric proportional hazards model to assess baseline factors independently associated with incident infection. I keep pressing the wrong thing. So as you can see here, the factors that were independently associated with hepatitis C acquisition in this group were younger age, so being younger than the sample median, which was 27 years, being a daily or more frequent injector in the 6 months prior to baseline, and not being on OST while mainly injecting heroin or other opioids in the last 6 months. So OST was protective against incident HCV infection and associated with a more than 5-fold reduced risk among those who mainly injected heroin in the HCV cohort. And interestingly enough, although there are 3 groups that collaborate in various degrees, the HCV was the first study to be published to observe this independent protective effect of OST against HCV infection. We now have evidence from Vancouver, from the VIDAS cohort, and San Francisco from the UFO cohort, which report, interestingly enough, very similar effects, about a 60% reduction in the risk of incident HCV. And you can see there the estimates from each of those studies. So interestingly, although they're very different settings, the effect of OST was significantly reduced across all 3 studies, and the effect size is quite similar. I want to share with you briefly some preliminary findings from a Cochrane-registered systematic review and meta-analysis we're currently doing to estimate the impact of NSP and/or OST on hepatitis C incidence. Preliminary findings from this pooled analysis suggest that the use of OST was associated with a 57% reduction in the risk of hepatitis C virus acquisition. So there's even stronger evidence for the combined effects of OST when you put it with NSP, and our results so far indicate that's about a 70% reduction in risk of incident hepatitis C virus acquisition. And obviously the prevention benefits of OST are likely to be more effective in best practice scenarios, so where doses are therapeutic and when accessed early, given high transmission of hepatitis C virus among younger people and recent initiates. Unfortunately, hepatitis C virus transmission in prisons remains an overlooked consideration where there's a need for both OST and NSP to reduce transmission. So despite recent advances in new direct-acting antivirals for hepatitis C virus infection, barriers to access and prohibitive costs mean uptake by people who inject drugs is likely to remain low. Prevention has to remain a priority. And I say this in the context of Australia, where our previous prospective observational cohort study observed an incidence of 44.1 per 100 person years a little over a decade ago. It's 7 per 100 person years now. What have we done? We haven't had hepatitis C treatment. We haven't had treatment as prevention, but we've got really good coverage of OST and NSP. among people who inject drugs. And we've got really good collaboration and partnership with people who inject drugs, and federal funding for peak bodies to represent their interests. So, in conclusion, the preventive benefits of OST extend to both hepatitis C and HIV. We have indications from a number of places that opioid use is increasing, and we've seen significant outbreaks of HIV among people who inject drugs recently in the US, Ireland, Israel and Greece. We need to remove these barriers, and we need to continue to invest in scale-up of not just OST, but combination prevention. I'd like to acknowledge my colleagues, and in particular the colleagues who are here at this meeting, Thomas Kerr, Margaret Hellard and Kim Page. And that's it.